in our society today, so I just thank you for coming here to learn more about it. We're really excited to have tonight Dr. Chad Sylvester from the Department of Psychiatry at Washington University, and I think you all should have gotten a pamphlet on your way in. If you didn't, there are more down here and there are some out still in the lobby. I also want you to know we will be live streaming this onto the Parkway website. We'll also be recording it, so if you missed something or want to refer back to something, that will be available. I also want to point that out just because this is a sensitive topic and oftentimes people ask questions. So just full disclosure that is being streamed, that part is being streamed. So just anything that you ask or say in the general vicinity here will be online as well. So just that little disclaimer for you. If you need anything in terms of bathrooms and whatnot out in the lobby, also you can just come find me and ask me. I will be happy to help you. But without further ado, our speaker, Dr. Chad Sylvester.
Hello, everybody. You guys can hear me okay in the back? I may decide to put the microphone down at some point, and if you guys can't hear me, just let me know. Thank you for having me come speak. As Aaron said, my name is Chad Sylvester. I am a child psychiatrist. I work at WashU, where I have a clinic that is specifically focused on treating childhood anxiety disorders, pretty much specifically childhood anxiety disorders. I treat kids that are anywhere younger than 18, so the full range of children. I also spend a fair amount of my time doing research. I'm trying to study the brain mechanisms that are involved in what causes childhood anxiety disorder. And I'll talk a little bit about that at the end, but I'm going to spend most of the time just talking about what I do clinically and about anxiety disorders, what they are, etc. I usually like this talk to be relatively interactive and hopefully useful for people. So feel free to interrupt me as I'm speaking. Either just raise your hand, or if I'm facing the wrong direction, I don't see it, it's fine. Just to yell out my name. As I said, I want this to be useful for people and get what they want out of it. So I'm going to start off by talking about a person that I saw in clinic a few years ago, just as an example of how severe an anxiety disorder can get. So just sort of an example. Rachel was a different name, but 12 years old at the time, and she came to our clinic for anxiety. And Mom described her as a worrier and said that Rachel was always worried about something. Whether it was an upcoming gymnastics event, the logistics of a trip that they had coming, was she going to pack everything, were they going to make it to the plane on time? She worried about upcoming social interactions, and whenever Mom would sort of reassure her about one thing, she would just start worrying about something else. And it got to the point where Rachel was just being homeschooled, not because Mom thought that was the best thing for her, but just because Rachel was refusing to go to school. There were just too many things to worry about, and she couldn't manage that worry. And when we first started talking to Rachel, she actually just refused to speak to us at all. She literally ran out of the office. And Rachel just had an anxiety disorder, no other psychiatric illnesses. And so that, again, the example is just to show that anxiety can be extreme and impairing at school, at home, etc. Of course, I wouldn't be presenting Rachel if I couldn't tell you that Rachel is doing a lot better now. It's been a few years. We have her on a number of treatments, and she goes to school, went to a gymnastics camp, etc. I want to just briefly go over a few definitions just so that we're all on the same page. The first thing to say about anxiety disorders when I use that term is I'm actually talking about a group of related disorders. So there are several different types of anxiety disorders that we see in kids, and I'll go over those. But they all have a few things in common. First, of course, there has to be excessive fear or anxiety. Fear being I'm scared in the moment, and anxiety meaning I'm worried about something that is going to happen or I think might happen in the future. And of course, it's normal to have fear and worry and anxiety. It's a normal human emotion. but we call it a disorder when it is excessive or it causes you a problem. And so it has to be outside of what's normal for your age, and usually the way that we define that is just, is it causing the child a problem in their life, again, at home, school, etc. The most common way that anxiety is impairing is avoidance. So kids will usually avoid whatever it is that they're nervous or worried about. And we'll go into details in the specific anxiety disorders. But kids can show their anxiety in other ways. So kids can just have like outbursts or become very angry when they're confronted with whatever it is that they're worried or anxious about. Or other kids just endure their anxiety with distress, and they're just always very uncomfortable, but they won't say anything. Often because of their anxiety, they don't want to stand out. So I'm going to talk about really 3 major types of anxiety disorders that we see in kids. And when I see a child in clinic, one of the first things that I do is try to understand which one or multiple ones of these types of anxiety disorders that a child has, because that helps us know how we can best help them. The first type of anxiety disorder that I'm going to talk about is called separation anxiety disorder. It's a pretty sort of intuitive disorder based on the name. These are kids that experience fear or distress when they separate from their caregiver. The most obvious example would be like if a kid's getting dropped off at school or daycare, they can be clingy and not want to leave. But they can come up in other ways as well. And some kids sort of get comfortable with a particular environment and don't actually show that problem with separation at school. But the common thread is that the child is worried that there will be something that will prevent them being reunited with their parent. So that can be that the kid is worried that something bad will happen to them. They'll get kidnapped at school, there'll be an intruder, or a natural disaster that will happen at school that will prevent them from seeing their parent. They might think that their parent is going to get into a car accident or not come back for whatever reason to pick them up. Kids with separation anxiety often also show symptoms at home. So lots of kids with separation anxiety will follow their parents around the house, even into the bathroom. They're just always there. Kids with separation anxiety sometimes will want to sleep in their own bed. They'll want to sleep with their parents or sometimes with a sibling. And if they do sleep in their own bed, they'll sometimes have nightmares, usually with the theme of something bad happening that's going to keep them from seeing their parents again. The second major type of anxiety disorder that we see in kids is called social phobia or social anxiety disorder. And I may sort of slip back and forth and use those terms interchangeably. But these are kids that, the easiest way to pick them out is the kids that are excessively shy, right? The first time they meet a new group of kids, they don't want to talk or they don't want to interact with the kids. A little bit of that is normal at the beginning of the school year. It can take a few weeks for kids to feel comfortable in the classroom. That can be normal. But if it's lasting for months and months, or it keeps kids from wanting to go to birthday parties, social events, that kind of thing, then we might think about social phobia. Again, the common thread for this one is fear of negative evaluation by peers. And this can come up in a variety of ways. At school, it can come up where kids don't want to get in front of the class and maybe give a presentation, write on the whiteboard. They often don't want to raise their hand and participate in class. Certainly giving like a speech or singing might be difficult. Sometimes these kids can appear to be very well behaved because they don't want to stand out, but they're constantly anxious. Sometimes kids with social phobia also won't want to participate in sports, and they're not always upfront about it's because of they're anxious, or they may not know it's because they're anxious. They may just say, "Well, I don't like sports," for whatever reason. And it can be individual sports or team sports. It's just that the kid always feels like people are watching them, are judging them, they're not going to do the right thing, etc. The third type of anxiety disorder that we frequently see in kids is called generalized anxiety disorder. So this was Rachel in the vignette. These are kids or adults that are always worried about something that may or may not happen in the future. So it's not being scared of something that's right in front of you, but worrying about something that's going to happen. And the topic can just change. And as soon as you feel better about one thing, you just start worrying about something else. This can be associated with physical symptoms like poor concentration, stomach ache, headache, although those symptoms we also see with other types of anxiety disorders as well. All right, and then just to briefly touch on specific phobias. So it's also possible, of course, just to have like a specific fear, so a fear of dogs, a fear of elevators, a fear of heights, a fear of going to the doctor or something like that. We tend to not see as many kids with only a specific phobia in the clinic because usually it's relatively circumscribed. But the principles that I talk about tonight are going to be the same for kids that have these specific phobias. All right, yeah.
Sorry,
No problem.
going back to social phobia real quick, have you ever had a child that's more outgoing that has social anxiety?
It's possible. It's relatively rare, but yeah, sometimes kids can have social anxiety or and they sort of they are almost they go in the opposite direction to kind of make up for it. Is one possibility. The other thing that can happen is that kids can get comfortable with a particular group of peers. So they're friends that they're close with, or their cousins or their siblings, and they may have no problem with those kids, and then it's once they see new kids that they have a problem. Or the other thing about anxiety is that it can be strangely specific to certain situations. So sometimes kids they'll really get nervous in sports situations or talking in front of the class, but not meeting new kids. We would still call that social phobia if it was causing them problems, like they really wanted to play basketball, but they just couldn't because they were just crippled with fear, right? So it's hard to rule out an anxiety disorder by saying they don't have this, because it can be so specific like that. It's a good question. Okay, so the first point that I want to make then about anxiety disorders is that they are very common. They're the most common form of psychiatric illness in kids, and they're the most common form of psychiatric illness in adults. And we have a lot of studies that look at how common psychiatric illnesses are. The exact numbers that we get vary from study to study and how we measure anxiety, but they're always the most common amongst all of the psychiatric illnesses. So they're more common than depression, ADHD, certainly things like autism. This particular study said that the rate by the time you're 18 is 30%. We think that the number of impaired kids is probably closer to about 15 or maybe 20%. So it's very common. The next point that I want to make is that most people that get an anxiety disorder at any point in their life, it usually starts during childhood. The median age of onset if you're ever going to get it, half of all people that ever get it had an anxiety disorder by the time they were about 10 years old. And then they might have had symptoms of anxiety even before that. It's just that they didn't get diagnosed with a full disorder at 10 years of age. So it tends to be something that starts in early childhood. And in fact, we even have some behaviors in toddlers, 2- and 3-year-olds, that predict whether or not they're likely to go on to have problems with anxiety. And it's nowhere near 100%, but it just brings home the point that whatever anxiety is, it's probably something that started very early, some change in the way the brain is developing. Sorry. Unfortunately, I'm also on call tonight, and I don't have to, I have somebody else that's going to manage the calls, but I have to leave my phone on. I apologize about that. Of course, the specific anxiety disorder, different anxiety disorders have different ages of onset, and just because half of all people that ever get an anxiety disorder have one by the time they're 10, but the type of anxiety that you have may change over your life. So we start to see separation anxiety in younger kids, about 4 to 6 years old usually. Social phobia tends to start more in middle school, and generalized anxiety disorder tends to start during early adulthood. But these are just generalities. We can see any of these disorders at any age. Okay, the next point that I want to make is that anxiety disorders, if you have one, it tends to be pretty persistent. So if all these numbers are ratios of, say, the column on the right are ratios, percentage likelihood of having a problem with anxiety in the last month, if you had a problem with anxiety at all in the last year. And so the higher those numbers are, the more likely that you also had anxiety recently, which is just a measure of how persistent the problem is. And anxiety, again, it can kind of go up and down. So as the school year starts, if there's something stressful at home, at school, we can see an increase certainly. But by and large, it tends to be, if you ever have a problem, you tend to always have a problem. And that's different from other psychiatric illnesses, most notably depression. So depression is a kind of related psychiatric illness that's defined by being sad or irritable or withdrawn. Usually it's associated with a behavior change. Depression tends to be episodic, so you can be depressed for months or even years sometimes in a row, and then it can just kind of go away on its own for a long time and then come back. That tends not to be the case for anxiety. Most kids, anxiety is very common, and most kids that have problems with anxiety when they're in their childhood and adolescence end up doing fine. So most of them don't have a problem with another psychiatric disorder as they get older, and they find a way maybe to accommodate their anxiety a little bit. They may pick a job where it doesn't come up as often, but most of them do fine. That being said, kids that have a problem with anxiety are more likely than their peers that don't have anxiety to have a range of problems as they get older. So is that distinction clear? So, and so they're at increased risk for a whole host, almost every other psychiatric disorder as an adult compared to other kids their age. Certainly other anxiety disorders as they get older, also depression. It turns out that most adults that have depression had anxiety when they were a child. Kids are at increased risk for having problems with substances, sort of the self-medicating idea. That could be alcohol, marijuana, cigarettes, or other drugs. Eating disorders, etc. And if you take sort of the whole population, people with anxiety can take a little bit of a hit in terms of their likelihood of becoming employed and that sort of thing. Although there are many other factors, of course, that determine that. A question that I get asked a fair amount is what causes anxiety? Why is my child anxious? And we think that it is a pretty even mix of genetics, kind of what you're born with, and your environment. So what kind of happens to you when you're a child. So anxiety runs in families. The genetic risk, sort of what you just sort of naturally get from your parents no matter what, we think is what shows up sort of in very early childhood. So kids that are like 2 and 3 and are really shy, you can tell already. Or they have what we call a kind of a vigilant temperament, where if something new comes into a room that they're in, even it could be like a new toy that sort of has loud noises and flashing lights, the kids will kind of stop what they're doing and like they'll kind of tense up and they might start to cry or something like that. So they get sort of, you can see that they have kind of a negative, large reaction to novelty or to new things. The other aspect is environmental, and there are associations like if there have been like a major life change, like the death of a parent, moving, divorce, those kinds of things, there's a slight uptick in your risk for having a problem with anxiety after that. But the biggest environmental influence are the parents, and actually how parents interact with their kids when they're anxious. It's not to say that parents are causing anxiety in their kids, but sometimes if a child is at risk, you can kind of push them one way or another through parenting. And so to give some examples of the different parenting styles that are associated with continuation versus stopping of anxiety, I'm going to give a very kind of simplistic example that is just meant to illustrate the points. It's not meant to be sort of a one-size-fits-all. So imagine that you have a child that you're dropping off at school, and they start to become, you can tell they're scared to go into school. So the type of parenting that is least associated with continued problems with anxiety is called authoritative parenting. And this is a parent that is warm and empathic, but also in control of the situation. So that parent might say something like, Johnny, I see you're really scared right now about going into school. I know this is really uncomfortable for you, but you still have to go into school today, right? So the idea is that you're connecting with the child, you're showing them that you see what's going on for them and you care about that, but you still expect them to sort of kind of do what they have to do. You're not going to sort of give in to the anxiety. And that's opposed to two other types of parenting. One type is called authoritarian parenting. These are parents that might be in control, but are not warm. So a parent like that might say something like, "This is ridiculous, stop being a baby, go into school right now." Right? So that parent is in control, but they are not sort of identifying with the child. They may not be that extreme, but the idea is they're not being sort of empathic. And that's associated with continued problems with anxiety in the child. The other type of parenting that is associated with continued problems with anxiety is called permissive. So these are parents that may be warm, may connect with the child, but they're overly permissive in terms of what happens. So they may say, "Oh, yeah, this is really tough. I see you're scared. You know what? Let's just go home and we'll try again tomorrow." Right? So, and the problem with that approach in general is that the child learns that the way to manage their anxiety is to avoid the situation. Because they go home, they're not anxious anymore, and they've learned an effective way of managing their anxiety. But it continues it, so the next time they go to that same situation, they're going to be anxious again. Okay. So just to summarize the first part of this talk, which is mostly sort of laying the kind of background information, anxiety disorders are the most common form of psychiatric illness at any age group. If you have a problem with anxiety, it tends to start in early childhood. Kids with problems with anxiety are more likely than their peers to go on to develop a range of other psychiatric problems as adults, even though most do fine. And then the flip side of that is that most adults with anxiety and depression had anxiety as a child. And so this is one of the main reasons why I went into child psychiatry as opposed to adult psychiatry, and also why I focus on anxiety disorders. Because I sort of see anxiety as a sort of an early sign of a child that is at a little bit increased risk compared to their peers of having problems as they get older. And the hope is that if we can identify kids when they're young, that we may be able to sort of mitigate that trajectory a little bit. Show some evidence that suggests that maybe we can, although we're not 100% sure. Questions about this stuff before I move on to the next part? Yeah.
When you mentioned the 3 types, you didn't mention anything about like discussing with the child that they have anxiety. Is that not recommended with children? Like explain what's going on?
It's a great question, and I'll touch base on that indirectly in a little bit, but to answer that directly, my general approach is to be very open and honest with kids about what's going on. So, usually I recommend that you don't have to say that they have a particular psychiatric disorder necessarily, but you can just let them know that you're seeing that they continually have problems, or they're shy a lot, or they have a hard time separating, and explicitly sort of help them become aware of what's going on in the moment. That's actually a really important first step in how we treat kids with anxiety. It's getting them to recognize their symptoms when they're happening, know what's going on, identify patterns that they're having in their life so that they can start to regulate it. There are very few occasions where we deviate from that, but for the most part, we try to be very open about that. Yeah.
Do you feel like the anxiety disorders are more prevalent now than they used to be? It just seems like it's, anybody that you run into, there's a lot of, that their kids are having those issues.
Yeah, I mean, I wonder this myself all the time. It's a very difficult question to answer, in part because it's hard to measure the rates of anxiety disorders anyways, because part of it depends on how severe you have to say the anxiety is before you call it a problem. And also, we think the expressions of anxiety kind of change over the decades. The best evidence that we have suggests that the rates are relatively stable over the last few decades, around 20%. But I wouldn't be extremely confident in that. It's a good question. Yeah.
Is the rate of
Not as far as I can tell, no. So the question was whether or not gifted or high IQ children are more likely to have problems with anxiety. In fact, if anything, it could be slightly the opposite. But anxiety is common in everybody. It's common in kids with high IQ, low IQ, average IQ. Certainly the expression of anxiety can change a lot, depending on sort of how aware you can be of it, the tools and the resources that you have to sort of manipulate or regulate that anxiety. And so we always have to take into account a child's cognitive abilities and what their strengths are and weaknesses are when we're thinking about how to help them with their anxiety and how they might express their anxiety. But we don't have any evidence that it's different, say, in higher IQ kids in terms of the rates. All right, so I want to spend the next part of the talk talking about what are the current evidence-based treatment options. So what can we do for kids with anxiety disorders? And we have a fair amount of research into this question, and they mostly all point at the same answer. So I'm going to talk about the largest study that we have that addresses this question, but there are a lot of other studies that show the same thing. So the largest study to address this question was started about 10 or 15 years ago. It included about 500 kids from 4 different universities around the country. And the kids had to be between the ages of 6, 7, and 17. And they had to have one of the 3 types of anxiety disorders that I mentioned at the beginning of the talk. So separation anxiety, social phobia, or generalized anxiety disorder. And then what was done was the kids were randomly assigned to one of 4 treatment arms. Less than a quarter, about an eighth of the kids got just a sugar pill. So they got essentially no treatment, although they were given the option for other things later on. A quarter of the kids got just a medicine. In this case, it was Zoloft, or sertraline is the generic name. That was sort of, a dose was adjusted every 12 weeks of the study. A quarter of the kids got just therapy, cognitive behavioral therapy, over the 12 weeks of the study. And then another quarter of the kids got both the medicine and the therapy. And the results were pretty straightforward. After 12 weeks, they just asked what percentage of kids in each group are either improved or very improved. And the first thing to note at the bottom is that the kids that got the sugar pill, about a quarter of them reported being better after 12 weeks. So that may be sort of natural fluctuation in symptoms or a placebo effect. And then either if you just got therapy or if you just got medicine, those 2 treatments were both better than getting a sugar pill. And they were about equal to each other. So they were equally effective, medicine and therapy. And about 55–60% of the kids in those arms got better. And then the kids that got both therapy and medicine did the best. About 80% of them reported being better or very much improved after 12 weeks. So pretty straightforward. Both medicine and therapy are effective, and the combination looks like it's more effective than either treatment alone. Usually the way that we interpret this in clinical practice is that for kids that come in with mild to moderate anxiety, we usually try to start with therapy and see how they do. For a number of reasons. One, it avoids the potential side effects of medicines for anxiety, even though they tend to be very well tolerated. It gives them skills that we think they can use the rest of their life, and we don't want them to not get those skills. There are cases where we go straight to both types of treatment. Certainly somebody like Rachel. Actually, with Rachel, we started her on medicine first because she was completely unwilling to go into therapy because she was too anxious. So that's the other thing that sometimes happens. We'll put a kid on medicine for a few months until their anxiety is a little bit lower, and then start them in therapy. So I'm going to spend a lot of the rest of the talk talking about therapy that we do for kids, because not because I think that every kid that has any level of anxiety should go into therapy, but because I think that there are specific elements that you can pluck from what we do in therapy, the sort of best practices for how to interact with anxious kids. Unless somebody has a question about medicine, I'm not going to come back to it. one of the important things to know about therapy is it's sort of like saying that you're on a medicine. So therapy is just a general term for having an interaction with a therapist. There are many different types of therapy, is the point. And several of those different types of therapy may be effective for kids with anxiety disorders, but far and away, the most evidence is for a particular type of therapy called cognitive behavioral therapy. So if you think your child is anxious and needs to get therapy, I always recommend parents specifically ask for cognitive behavioral therapy in most cases. One of the things that's nice about cognitive behavioral therapy is that you can sort of get basically cookbooks for how to do it, where you have a specific plan that you're doing each week for, say, 16 weeks. And then you can kind of reassess at the end of that time whether or not the therapy worked, as opposed to, say, therapy being sort of an endless thing that goes on for years and there's no kind of end point or time where you kind of clearly demarcate a time where you reassess. That doesn't mean that everyone can just kind of only go through those 16 weeks. Something can often get more complicated than that, but it's a good starting point. We, at our clinic at WashU, offer a specific implementation of cognitive behavioral therapy for kids called Coping Cat or the CAT project. But there are other types that are probably just as effective. So, in general, the cognitive behavioral therapy for anxiety disorders can be broken down into two halves. So sort of the first 8 weeks and the second 8 weeks. The first 8 weeks are spent really getting the child to be sort of aware and mindful of their symptoms in the moment as they're happening, and then learn ways to regulate that. And we break it down. So we have a session where we spend the child just learning how to identify their feelings, and in themselves, and other people, and characters in a book, and have them do that both in the office and then in between sessions. There are other sessions during that first 8 weeks where we just focus on body sensations. So what's going on in your body when you become anxious? Another session is spent on thoughts. So what are the thoughts that come into your head, and how do those continue or make your anxiety go away in the moment? We also teach kids mnemonics to kind of quickly be able to access this stuff when they become anxious. We also teach them ways to regulate themselves in that first 8 weeks. The specific way that you teach a child to cope with anxiety is probably not as important as how it's done. I think I have some slides in a bit that will talk about a little bit about that. The most common coping mechanism that we use is deep breathing, so simply having the child sort of focus on their breath and breathe slowly in and out, usually kind of counting in their head or looking at a clock so that they can make sure that they're slow. We'll talk a little bit more about other things to be aware of as you do in a slide or two. But there are other relaxation techniques, so progressive muscle relaxation, or imagery sometimes, or squeezing and relaxing of particular individual muscle groups. So that's the first 8 weeks. There's also a parent-only session because it's also important to make sure that parents are aware of what's going on and reinforcing that at home, and not reinforcing anxiety, for example. And then the next 8 weeks is really important. So this is the what we call gradual exposure therapy, or it's exposure therapy. And what we do for this 8 weeks is we have the child and the parent and the therapist kind of work together to come up with a list of the child's fears, the different situations that they might get in that would make them anxious. And we rate them on a scale of 1 to 10 in terms of how anxiety-provoking they are. And we try to make sure that we have the whole scale filled out. So we want to make sure we have 1s and 2s and 3s and 4s all the way up to 9s and 10s, where those are like their biggest fears. And then what we do over the next 8 weeks is we intentionally have the child do those things that make them anxious. And we do that both in the office and then as homework in between sessions. And we start with the easy stuff. We start with the 1s and the 2s, and by the end of it, our goal is to get up to the 9 and 10s, of course, as long as they're safe. And what this does is it teaches the child, one, to use the stuff that we taught them in the first 8 weeks, both sort of practice being mindful of everything that's going on and then regulate it. But it also sort of has this implicit kind of training where your body just sort of learns and kind of gets used to the situation slowly. And it sounds really scary to kids and parents when we first describe this, but kids build up momentum. Once they start off with that easy stuff, they really learn, oh, I can do this. I can succeed at this. I can do the stuff that I was taught. And they tend to be okay by the time that they get towards the end of that. So what this slide is then is sort of, again, not every kid that has problems with anxiety needs to go into therapy. Usually best practice is to do it for about an hour a week, maybe every other week, for at least 16 sessions or 12 sessions, and so it's fairly intensive amount of time. It's not for everybody. But you can sort of distill from what we do in therapy in terms of little things that you can do gradually over time to sort of help your child if they have anxiety. And the first thing is, I was talking about parenting styles that are associated with anxiety going away. And that is to be sort of empathic but firm with your child when you notice that they are scared, right? So again, that's sort of showing them that you recognize their emotion. You're also telling them what that emotion is, because a lot of times kids just know that they don't want to do something or something is happening, but they can't even really identify that it's a feeling that's driving all of that. So helping them recognize that by being empathic. But also, again, in general, expecting them to continue with whatever it is that makes them anxious. And so the next step is sort of the first 8 weeks of CBT, right, which is to help kids understand their thoughts, feelings, and body sensations when they're scared. And this is a very sort of gradual thing to do. This does not happen overnight. It happens over the course of years. And every child is starting off from a different spot. And so the goals are going to be different in different kids. But say feelings, right? If your child is anxious or has other psychiatric problems, actually, it's good to help to get them to try to label their emotions all of the time, both when they're having positive emotions and negative emotions. And some kids are very good at this naturally, and a lot of other kids are not. Like they just don't have the language to do it. And it's also not, if you listen to sort of interactions between people, not done that often. So lots of times when there's a disagreement about a kid going into school or something like that, it's all about the behavior, whether or not the kid's going to go into school, right? Because very rarely does it start to involve, why don't you want to go to school? Well, because I'm scared, right? It's usually why I just don't want to, or I'm really doing something else. So asking the child how they're feeling is a way to start. A lot of times they won't be able to identify their emotions, and then you might do something like label it for them. You just kind of get in the habit of doing that so that you kind of get used to sort of hearing this label come every time that they experience that emotion. And you may have to guess a little bit. Label your own emotions, right? So get in the habit of talking about how you are feeling, again, both positive and negative, just so that the child learns that emotions are a thing that we talk about, and other people have emotions, and it's sort of normal to talk about them, right? So sort of coaching your child on learning what emotions are and when they come up, etc. And the same thing for body sensations and thoughts. So asking the child various things. And again, helping them, again, back to the question about communication. Let them know that you're noticing this pattern, help them identify it in real time. So the next piece kind of gets back to the coping skill thing. So as I said, it's not critically important which coping skill a child learns. You kind of let them pick and go with it. But it is really important how you practice it. Because I hear all of the time that coping skills don't work, or particular coping skills don't work. And sometimes they don't, but usually the description goes something like, my child was, at the store, and I told them they couldn't get something, and it was really, they just had a complete meltdown. They started kicking and screaming. They were completely lost it. And I told them to do their deep breathing, and it didn't work. So that's obviously a setup for failure, right? I mean, the child is completely overwhelmed, right? And you're asking them to do something that somebody told them at one point was going to be helpful. But that's not what we do in therapy, right? What we do in therapy is we practice a coping skill first when the child is not anxious at all, not overwhelmed at all. So it becomes like a habit. Other things I like to say is it's a skill to learn. It's not a knowledge, right? It's not like what's the capital of Missouri, right? What's my coping skill? It's a skill that you have to learn, and you have to learn it in easy situations before you try to practice it in more difficult situations. Again, it's sort of like a sport, right? So if you're learning how to play baseball, you wouldn't just explain to a child how to swing a bat and then put them in front of a kid that can throw the ball 50 miles an hour, right? You start off in small steps and kind of get them used to doing it. And so that's the idea. So if you want to do something like deep breathing, you might practice it every day at bedtime, for example, or some other time when the kid is completely calm and can only maybe for a minute, something like that. And then if they get, then what we do in therapy, right, is we gradually expose kids to their fears. So as you see them do something that's a little bit difficult for them, then maybe remind them of their coping skill. And then kind of keep upping the ante on them a little bit, right? But again, the idea is to have them build confidence and learn how to use the skill slowly over time. The next piece, again, is a general point, which is to be careful about not reinforcing avoidance as a coping skill. So again, if a child is, say, going to go to basketball practice or something like that, and they don't want to go, and you think the reason is anxiety because they're scared about being around other kids, and then they don't end up not going and staying at home, their anxiety has gone down, and they've learned an effective way of managing their anxiety. The problem is that the next time they get into that same situation, the same sort of pattern of things is going to happen. It's going to be a habit that's going to form. As opposed to learning that if they go, their anxiety kind of goes down over the course of the practice, they're fine by the end, and maybe they liked it, right? And so they're learning something completely different. The last point is related to generalized anxiety disorder. So a lot of things that I've been talking about have been sort of putting them in situations where they're anxious, but what do you do with a child that always just has something that they're worrying about? Like whenever they stop worrying about one thing, they worry, start worrying about something else. And usually the dynamic is that the child is constantly looking for reassurance from their parent, so that they want the parent to sort of regulate their worry by convincing them why something isn't going to happen. And so what we do in that case is we try to get the child to just learn how to contain their worries. And so what we usually recommend is something like a worry time. So a time that is about 15 minutes a day where the child can go to the parent and just get reassured as much as they want about whatever it is that they're worried about. But the rest of the day, if the child brings a worry, you just have to say, we'll talk about that during the worry time. So it's okay to think about things and plan for things, but we want it to be circumscribed, and that teaches them that. All right, so the last few points to make are that, for the most part, I've been talking about just treating anxiety and not other forms of psychiatric illnesses, but anytime we do an intake on a new child, we're trying to think about what is challenging a child, we also have to think about every other psychiatric illness, because as I mentioned earlier, if you have anxiety, you're more likely to have a lot of other things as well. And those other things can get in the way of your anxiety getting better. So if you also have ADHD, if you also have depression, if you also have autism, we have to think about how those things are interacting with the anxiety in order to effectively treat all of those things. The other important piece to mention is that it's also important to make sure that any problems in the parents' mental health are addressed. So it's very difficult to treat a child with anxiety if their parent is very anxious, for many reasons. One, the child is seeing their parent being anxious and they're learning from them. Sometimes the parents can over-identify with their child. They can sort of recognize, oh, I went through that, it's awful, I want to shield my child from that, right? And that would prevent some of the exposure stuff from happening. Or sometimes the parents can just also be very nervous about whatever it is that the child is nervous about. And so it's important for us to always ask about parents and have their mental health needs met. Of course, we always have to look for stress that's happening. If the kid's being bullied, then it doesn't make sense to think about their anxiety or having some sort of social phobia, because they have a real thing to be worried about, right? So we have to always make sure that there's not something like that. Excuse me. I cannot overemphasize the importance of sleep. Kids that are in elementary school need 10 hours of sleep, 12 hours of sleep. It depends on the child. Every child is different. But if the child is consistently getting too little sleep, it's almost impossible to help them with their anxiety. Now, of course, sometimes they go hand in hand, and so we have to think about how do we address sleep problems in a child that has anxiety. But the point is that that's where you want to start if that's going on. Sometimes if I talk to high schoolers, they and their parents will say things like, well, there's no way we can get more sleep because there's so much homework and activities and everything else that my child can only get 6 hours of sleep. And there's very little we can do in that situation. So if your life is set up such that it's just not possible, it really means that you're just tolerating having a high level of anxiety because there's other things going on. Diet, there's no specific sort of foods that are bad or something like that, just sort of a general recommendation to have a balanced kind of healthy diet. Okay, and then I mentioned at the beginning that kids that have anxiety are at increased risk relative to their peers for having a lot of other problems as they become older. We have some evidence that suggests that kids that respond to treatment when they're young don't have that increased risk by the time they become an adult. It's not the same as saying that kids that get treatment are better, but kids that respond to treatment do better as they become adults. All right, so this is sort of the summary slide, and as you can see, we have some effective treatments for anxiety, but the truth is that they don't help everybody. So you saw that the response rate was about 80%, so 20% is still a lot of kids. And that's also the best case scenario because that's after 12 weeks, right after the child gets treatment. Unfortunately, a fair amount of kids sort of kind of regress back to where they were, so that after about, say, 5 or 10 years, the rates are more about 50% of kids that are better from when they got treatment. So we still need more treatments for anxiety disorders, and we need, in order to do that, we need to learn sort of more about the basic biology of anxiety. And so I just want to spend the last few minutes talking about some of the research studies that we're doing, and then I'm happy to stick around for as long as people want to ask questions. I'll just sort of briefly say, and then I'll let some other folks come up here, that the main studies that I have going on are looking at anxiety in kids that are between 8 to 12 years of age. And we are looking at how they pay attention and how their attention kind of gets grabbed by things that are scary to them and gets stuck on that stuff. And so we have computer games that we have them play that sort of assess that. We also have them get an MRI. So we're looking at their brain function. It's completely safe because it's a big magnet, there's no radiation or anything like that. The kids usually love it actually, they get a picture of their brain. We also have a treatment study, but it's experimental. We don't know if the treatment's going to work, but we're trying to see if we can have kids play very simple computer games that might retrain their attention in a way that might make it less likely for them to continue to have problems with anxiety. I also want to mention that it's also really important that we have participants in the same age, 8 to 12, that don't have anxiety, because of course we need to compare the brains of kids that have anxiety to kids that don't have anxiety. But I've told you most of it, but I'm going to let Jennifer say just a few more things about that. And then I also have another colleague, Dr. Gilbert, who is looking more in the early age range, so kids that are 5 and 6 years of age, because again, we think that's when anxiety might start. So she'll tell you a little bit about that. And then again, I'm happy to stick around for other questions about anything after that.
Hi everyone, so my name's Jennifer, and like Chad said, I work on his research side of things. So we currently have 2 studies that we're recruiting for, and so the blue brochure that was out on the table outside that outlines the novel anxiety treatment, which Dr. Sylvester was talking about. So with that research study, there's 12 visits associated with participating, and so we have kids come in for 4 weeks, twice a week for 4 weeks, and they come in to complete this cognitive training program. And so Dr. Sylvester has designed it, and it's a simple computer game looking at some different shapes and faces on the computer screen. and it takes about 30 minutes to an hour for each session. And so both before and after that session, both the child and the parent will complete a full psychiatric diagnostic interview. We have the child play some computer games, and they'll also get an MRI scan. And like you said, they get to take home a picture of their brain, and every kid thinks that that's just so awesome. So they do that both before and after the 8 sessions, I'm sorry. So that's 2 visits in the beginning, the 8 sessions, and then 2 visits at the end. And you can earn up to $400 for that research study, and again, the ages are 8 to 12. And so then we have another research study that we're doing that's a little bit shorter, and so this one we're looking for kids both who struggle with anxiety and also who don't struggle with anxiety between the ages of 8 to 12. And they'll come in to do a psychiatric diagnostic interview, both the parent and the child, complete some computer games, the computer tasks where we track their eye movements. And then they'll also receive an MRI and get a picture of their brain. And so for that study, you can earn up to $150 for completion of that one. Yeah, so of the psychiatric diagnostic interview, we actually send a follow-up letter with the results of that. So if they meet criteria for any diagnosis based on the research that we're doing. Yes?
Do you have any studies going on for kids that have already have IEPs early in school?
Not that I can think of, but I have a link that I could send you.
So if they've been diagnosed with an anxiety disorder, do you do any studies on for them, or you're looking for kids that have not?
No, it's okay for them to have been diagnosed. So it depends on what the IEP is. The best thing to do if you have a question is just to kind of call and go over the specifics, and then if it doesn't work out, we can provide other resources and let you know about other studies that are going on. It just depends on the situation.
So is your study essentially looking at neurotherapy or looking on neurofeedback, or is this
It's a little bit different. So usually when people are talking about neurofeedback, what they're talking about is they're looking at some report on what's going on in their brain and then trying to sort of modify that brain activity in some way. This is different. So what we're trying to do is we think we have an idea of which parts of the brain are functioning differently. And again, it's in terms of kids with anxiety having their attention and grab on things like straight. And so we designed a game that it might be kind of certain, but it's outside of the standard. There's no measurement of brain activity here. We just look at brain activity before and after to see if their anxiety is better, and then see if
And hi, my name is Dr. Kirsten Gilbert. I'm a clinical psychologist, also faculty at WashU and a colleague of Dr. Sylvester's. As he mentioned, we know anxiety starts very young in early childhood. So I have a research program that is looking at signs and symptoms, risk factors for anxiety in kids, like he said, age 5 and 6. So if you're a parent of a 5 and 6-year-old, again, we're looking for both healthy 5 and 6-year-olds or 5 and 6-year-olds that are kind of showing perfectionistic qualities. They might be self-critical. They might be exhibiting anxiety already. We'd love to have you come in and participate. It's a great way to contribute to science. The kids play games. They win prizes. The parents do interviews, and also you can make up to, what is it,
$190.
$190, not quite 400, but it's only a one-session deal, so it's a little bit shorter for the 5 and 6-year-olds. But again, we'd love to have you participate. I can answer any questions you have afterwards as well, and I'll make sure if there's questions about the talk more generally that I'll hand this back to Dr. Sylvester.
All right. Any other questions? Yeah.
So when you were talking about like the coping, you were talking about starting to label your own emotions. So what would your recommendation then be if you are a parent who struggles with anxiety? Like you don't want to be walking around going, I'm feeling anxious.
That's a great point. So you sort of have to walk the line of being honest. And again, this, I give sort of general recommendations, but of course it all depends on the particulars of what's going on. But in general, I encourage parents to be relatively honest about maybe even them having difficulties with anxiety, sort of like this runs in the family, and yeah, I get anxious as well, just like you do, and sometimes it causes me problems, and so we're going to work on this together. But yeah, you don't want to be sort of inundating the child with all of the times that you're having anxiety, but it's okay to be upfront that it comes up for you as well, in general, right? But you also want to make sure that you're labeling your positive emotions as well, right? Like it's sort of the yin and yang. And then the other, of course, thing to say about that is one of the best things you can do for your child, if they have anxiety and you have anxiety, is receive treatment yourself, because that can go a long way towards helping the child, in part because it just becomes a lot easier to sort of help them regulate and not get overwhelmed if you yourself are not having a problem regulating and getting overwhelmed.
Talk about coping skills, and what are some of the easy coping skills? I know that the therapy would go more in depth, but just some easy ones that we can try to integrate into our life.
So I talked about a few of them. I can expand a little bit. One of them is deep breathing, and I think it doesn't have to be long. Like you can just practice this for, say, a minute a night. Usually you want kids to sort of, they can put their hands on their stomach, and they can count to, say, 6 as they're breathing in, 4 as they're breathing out, and then maybe holding their breath for 2 seconds. If that's too complicated, just do like 5 and 5 or something like that. The point is that to slow them down. Other things that can be helpful are to like squeeze your fist, right, or something like that, and then relax it. Other things that can be helpful are like body scan, so kind of working your way down your body and just kind of noticing sensations and trying to consciously relax each of those things. The other thing to say about this is coping skills are an important part of anxiety. Another important thing is the gradual exposure part. And the gradual exposure part can work even if the child has not really bought into the first 8 weeks of our treatments very well. So for example, younger kids who might not even do a whole lot of that first 8 weeks, they can still sort of learn implicitly by getting used to things that they're not as anxiety provoking. So if I were going to focus on, say, a child in general, I'm more focusing on that gradual exposure piece than I am about like making sure that I've hammered home a coping skill. But both are important. The front and then behind you.
Do you use
Meditation
medication?
is very, the principles of it are similar to some of the things that I've described. And meditation can be useful for some kids with anxiety. And occasionally we will teach kids how to meditate. It doesn't have quite as much evidence as CBT, and so usually we start with that. But they're so similar in terms of being mindful of what's going on and sort of just letting things happen without feeling like you have to react to them, that I think it can probably be effective for kids. It can be especially useful in a group setting too, right? Because you can teach a classroom, say, how to meditate, and you may help multiple people as opposed to, say, one child. Do you have a question?
I have a question about gradual exposure. Some fears they're not concrete, like a child that worries about the future, worries about those things that are going to happen, say on a trip or if we do that. And how do you gradually expose them? Do you talk to them about, well, if this happened, what would we do? Or I'm not certain I understand that piece of gradual exposure or something that's not concrete.
Yeah, it's hard, and sometimes we have to adapt and use other tools other than the gradual exposure piece. And it depends a little bit on what you're talking about, because you talked about a few different things there. Something like travel, for example, you could, YouTube is a huge help for gradual exposure therapy, because you can find a video that shows almost anything. And in fact, you have kids that have fears of vomiting, and sometimes you show them videos of people vomiting just to kind of get them. So you can get creative, and you can use YouTube. But yeah, if they're worried about, say, what's going to happen in the future, then it becomes more about generally helping them sort of calm down and relax. For example, something like meditation or deep breathing or something when they notice this happening. And also to help them learn how to contain it on their own. And that's easy to say and hard to do. But the idea is that you help them learn that they can sort of think about that at times, but that if it comes up at other times, they have to sort of recognize it happening and then calm themselves down and do something else. And as a parent, what you don't want to do is get in the habit of always reassuring them about whatever it is, or talking excessively about how it's going to be okay or what's going to happen. You can do that, and that's helpful to do, especially with a therapist, maybe once a week, but you don't want to be just doing it constantly throughout the day, all day, whenever it comes up, if that makes sense. Yeah?
As many as 30% of students or children having anxiety, do we have any mechanisms for preventing it from happening, number one? And the second thing is, do you think something needs to change in the school curriculum
I think those are great points. So right now, the preventative efforts are sort of watered down versions of the things that I've been talking about. So they're taking kids that are at high risk for anxiety and having them, and especially their parents, really sort of learn about the principles that we're talking about here and implementing them. Early socialization. So kids that are really young that are showing signs of anxiety and are shy, it's probably best to try to get them into something like daycare or some other setting where they have early socialization with other kids. Same sort of principle, right? They're sort of getting used to something that is a cause for fear of them, and doing other sorts of things like that. Those are the main sort of preventative efforts. Really sort of a typical kind of version of CBT, and taking kids that are showing early signs and doing those types of things. I do think, and I think schools are doing this to some extent, I do think that there have been changes to school curricula that have been helpful. And I don't know what the long-term impact is going to be, but for example, one of the first things, my kids go to Robinson and Knifer in the Kirkwood School District, and they do things like label their emotions when they come in first thing in the morning. It might start off with a number, but then they're just supposed to say how they're feeling. They have counselors come in sometime, and I was talking with Aaron, and I know they do it at Parkway as well, where they give sort of general education on recognizing emotions and, again, like feelings and body sensations and that kind of thing. And it's hard to know if that is going to be effective or not, but I think it's a good idea. Yeah. Sorry.
I was wondering if you could talk for a minute about reinforcement avoidance, and when you have a child who refuses to go somewhere or do something that you want them to do or they need to do, how do you not reinforce it? How do you, like, there's things that force them into the car, how do you handle that?
So it's tricky, and it is easier when they're younger, and you can just kind of pick them up and so, and you can't always do it. And the idea is, I guess why I said it's sort of a simplistic kind of overgeneralization. The other thing to remember is that you want to do things gradually. And as they get older, you really want them to be on board with the plan and buy into the plan. And usually that's done by explaining to them sort of what the plan is, right? In terms of, here's how we're going to do this exposure therapy, here's how we're going to start off, right? And we're going to gradually get you up to this point, right? The other thing is we use rewards. So we in therapy, we come up, parents of course have to agree that it's a reasonable reward, but we come up with rewards for doing the exposures. And you have to kind of get creative. Different kids are motivated by different things. Some kids are motivated by time with their parents, just like being able to have one-on-one time with their parents. I had one child where we were having a hard time until we learned that she could, at the end of each session, could make a video on her mom's cell phone, sort of explaining to other kids why they should do exposure for their anxiety. Sort of like, this idea that I'm gonna make a video that's gonna be, other people are gonna see, that's gonna tell kids how to help their. I'm gonna be the teacher, right? She never actually posted that or anything, but it was still sort of the idea. So you want to use gradual exposure, you want to use rewards, and you do it for older kids. You have to get buy-in. You can't just physically pick up an older child.
So do you discourage the opposite end of that? Like, if you don't do what you need to, there's a consequence for not being able to, or that's not advisable?
It depends so much on the particular situation, what it is that you're asking them to do, right? I mean, if you're asking them to clean their room, right, then yeah, it's appropriate to have a punishment. The other way to do it this is just a slight variation of what you're saying, is to more sort of give sort of natural rewards for doing things, right? So say, and it could even be stuff that they're already doing. But let's say that they really want to get ice cream or something like that, right? They say, yeah, we'll get ice cream after you go to basketball practice because that's what you do after you've exercised. It's okay to have a little treat, but it really doesn't make sense to have a treat if you haven't sort of done that or something like that, right? Where you're, rather than punishing them, you're sort of not giving them a reward that they could earn. But it really depends. It really depends on what the punishment is, right? Like, and what that punishment, how that is related to what you're asking them to do, and et cetera. So I don't know if that's helpful, but I can't give you like too specific advice. Somebody else?
Is there any correlation between children with anxiety and screen times?
I don't specifically know the answer to that. I haven't seen any evidence to suggest that that's true, other than if you're spending a lot of time in front of the screen, there's a good chance you're not doing other things that might lessen anxiety. So if you have social anxiety and all weekend you're playing video games, then of course your social anxiety is going to increase because you're not going to the mall or whatever it is that people go to now, right? Seeing other people, engaging in the world, right? So you're missing that opportunity. The other thing that video games can do is there's such a powerful reward for anybody, especially the kids, that I'm sure I don't have to tell you guys this, but once you stop that, right? Once they have to stop playing, it can become a major problem, right? And so the biggest problem that I see with video games is kids having tantrums and frustration when they're asked to stop, right? And that's a whole other sort of emotion regulation thing that needs to be addressed. And usually for that, things like consistency and like knowing in advance what the limits are and really following through with those limits. So there's no blanket recommendation. I think Pediatrics Academy for Younger Kids suggests like less than 2 hours a day. But it's really more about making sure that kids are doing a variety of different things, not exclusively playing video games or electronics or whatever it is, and then having like specific limits. Yeah.
So in regards to homework, so we have a certain amount of time, kind of going back to the question earlier, we have a certain amount of time to get things done, and you're trying to get them, you have this anxiety. So do you have any recommendations on how to handle that? And then the other thing I had was about school accommodations. Do you see any things that you can ask for that might help?
All right, so the homework question. So it really, again, depends on the specifics of what exactly it is about the homework that's providing the anxiety. Usually the problem with homework is more kids don't want to have, they don't want to sustain attention for long periods of time, and so it's more like I can't make myself sit here and do this, more than it usually is anxiety. If it really is anxiety, like there's like I can't do this, something's this is going on, and it's, especially if it's at home, that's relatively rare. I would make sure that it's not something else first. But yeah, then I would sort of work with the school to come up with a gradual plan. And it depends on the specifics, but it could be sort of increasing homework over time. It could be specific subjects, right, that you would have them do homework in. But you want to work with the school to sort of really sort of pin that down. And at most elementary schools, I think, are kind of dialing back the amount of homework that kids are getting in favor of doing other things like playing outside and that sort of thing. The second question is good. So it's about accommodations at school for anxiety. And the most important thing I can say about that is that you want to develop a plan for that, and usually that plan should involve progression of those accommodations being gradually reduced. Not always, but usually. And it's the same, because it's all the same principles that I've been talking about before, right? Like accommodations could be another form of avoidance if they're not done well. But you also can't put a child into a situation which they're going to become completely overwhelmed and not be able to manage. So, for example, I will almost never sign like a child should stay away from school, right, because they're anxious, unless it is part of a written plan about how that child is going to work their way to get back into school, right? Because again, the idea is that's not the end point. You know, we've got to come up with a plan sort of gradual exposure to get that kid back in school. And in general, I would say that's the approach that you'd want to take with accommodations. But again, this is not a one-size-fits-all. It really depends on the specifics of the situation, but in general, that's how I would think about school accommodations. Yeah.
How do you approach a child who is resistant to therapy or has had bad experience with therapy or is very hard
Please go ahead, sorry.
Who thinks that they're smarter than therapists?
So, where to start? So, resistance to therapy. So, it depends. Of course, it depends on their level of resistance and what they're resistant about. I think if they're really anxious and they're super resistant to therapy, then that is the case where we sometimes start with medicine. So that's another option that you might consider if the anxiety is moderate to severe. The other things are the most important predictor if a kid's going to do well in therapy is their relationship with the therapist. And so sometimes you can get kids to buy in and you say, look, just meet this person once or twice and see how it goes. And if you have a good relationship with the person, great. If you don't, then you won't come back here. And if they don't have a good relationship, in fact, it's probably not that helpful to keep pushing them unless you think that over time that might change. The other thing you can do is, in worst case scenarios, you can try to do a little bit of the therapeutic stuff yourself, right? And so bring in some of the principles that I've talked about. There's books that you can buy that might help you. You know, coming up with rewards, right? You know, like if you go to therapy, you know, then you'll be able to do something else that you want to do. Some people consider that bribery or whatever, but if you know, if you have to be motivated with something else that's reasonable and helps you overcome some other problem that you have, I think that's a good thing to do. And it also sort of teaches you another skill, which is like to reward yourself if you do something that you didn't want to do as a way of doing something that you don't want to do, right? Because we all maybe do that, right? Like, I don't want to do this, but I tell them if I do that, then I'll get to do something else fun later on, right? So it's an okay contingency to sort of teach your child. If they think they're smarter than the therapist, so again, having them meet them a couple times, see how their relationship goes. The other thing is to remind kids, and this doesn't always go so well, that you're not going to a therapist to have them sort of teach you anything. And so there's nothing that you're going to like learn from this person necessarily in terms of like facts. They're like a coach, right? And remind them that even the best athletes in the world have coaches, right? I mean, LeBron is probably a better basketball player than any coach he has, right? But he still has coaches. And same with tennis players and baseball players, et cetera, right? So what you're really getting is a coach to sort of get you to practice things and develop specific skills. And so it doesn't matter if you're smarter than the therapist. Well, that's going to not work for every kid, but it's the truth. And if that doesn't work, it may not actually be because they're smart. They may just not want to do it for some other reason. Yeah. Sure.
Okay. So what advice could you give parents who maybe realize there's a change in their child, whether adolescents or teenager, maybe the school picks up on it, they're visiting the counselor at school, and then the counselor maybe says, you know, it's getting kind of past our point of being able to help. What recommendations would you give to parents on how to get into the mental health system? Because it's not easy to get into.
It's not easy, and I unfortunately don't have a great answer for that question. I think first start with your pediatrician. So pediatricians are the first line in terms of managing certainly some things like ADHD, hopefully anxiety or depression. You can also let them know that WashU has a hotline that pediatricians can call to get advice from a child psychiatrist at WashU anytime they want, and we have someone that always manages those lines every day. I guess I'm the one managing that. The other thing is, you know, if you can start with a therapist, it's easier to get in to find a therapist than it is to see for example, a child psychiatrist. And many kids that's fine. They can do CBT and they don't need maybe medicine or another assessment from, say, a child psychiatrist. And so if you call your insurance company and ask them for CBT or something like that, usually the insurance company would know providers in your area. We have a list of resources that we provide for people in this situation, but it is tough. That being said, we called a few, I had some of the staff call the psychiatrists in the area recently because this comes up so much, and you can usually get in maybe 2 or 3 months if you call around a little bit. That may be optimistic. But the point is that if by the time you talk to your pediatrician and you try to find a therapist, hopefully by then you might be able to see a child psychiatrist. Yeah, you guys in the back there.
How do you redirect a 12-year-old who wants to buy her own house? And yeah, and my catchphrase is let's be 12. Let's do what 12-year-olds do. But I love that she has a goal. Like, this is what I want my house to be. I love that part, but I want her not to worry about that now. And let's work on algebra.
Never had this question.
Yeah. This is my real life.
Maybe I might need a little bit more, like the child is seriously wants to buy their own house.
Well, it was a family joke until a friend of mine found a YouTube video of a 14-year-old who bought a house. I'm like, okay, now this is getting too real. Like, she's like, well, when I get my own house, and then she has plans, and she's smacking her hands together, like this is what she wants to do. And I love that, it's kind of out there, but I love that she has a goal of how she wants to manage her life, but not yet. Like, give her a minute.
Do you think it's a sign that she's really, she's anxious, like she's worried that she's not going to get a house in the future, or that she needs to plan for it now, or it's not going to happen, or she's just really excited about when she gets to buy a house?
I think she's excited about becoming a grown-up, and she's getting responsibilities. So she's like, okay, I finished this, now I'll finish this, and I have to get the house going. And we're like, you got time, kid. She's putting this pressure on herself. We never said you have to leave.
So she is putting pressure on herself.
Well, I think this is a little not unrealistic. I think it's a little, it's a big step.
Well, I think there's lots of different ways you can handle that. You're probably doing the right thing. I think, think about what she's probably trying to tell you underneath that, right? Which is that she's feeling like she's ready for more independence, or maybe get her to elaborate on what it is about the house that she likes. I mean, she's maybe again communicating something else to you and maybe talking about that. I think as long as it's contained, I wouldn't stress about it too much. You can get her to write about it if that makes her feel better. Sometimes if people write things out, then they don't sort of keep coming back to the same thing over and over because they realize that it's sort of the same thing that's coming up in their mind over and over. I don't have any other advice.
Do you have a go-to or favorite resource or book that parents can try to use at home to implement strategies for general anxiety? And do you have one that children can use, like a workbook or that kind of thing?
Yes, we have a list. We don't have it here. You can email Jennifer Harper at Woolsel.edu. It's on one of the brochures, and we can. Okay, great. I think you've been waiting for a while, maybe, so I'll come back. I'm sorry.
I'll ask. It's kind of back to like getting into mental health. If you're looking for a therapist for your child, obviously you go to your pediatrician. But how do you gauge success? Right? Like I went and had a meeting with a therapist before I trust really my child. But how long should I wait to gauge success? And then how will I gauge success for generalized anxiety?
So your therapist should be able to answer those questions, and those are really important questions, and it's a good barometer about what's going to happen in therapy if the therapist can answer those questions, because they should be able to say something like, here's what we're going to do over the next 12 to 16 weeks, here's the plan, and here's how we're going to tell whether or not things are improved or not. And you and your son or daughter, right, should be involved. Usually it's concrete things, right? Like, I I'm sleeping in my own bed instead of crawling in bed with my parents, or I'm going to basketball practice, or whatever it is. So usually if you have sort of concrete goals like that, it's a little bit easier to assess.
And just to follow up on that, I see that obviously CBT is kind of like the go-to for anxiety. Is there any kind of benefit for talk therapy, like adult would do, to gain real insight into oneself? At what age can that be? Or is that all the talk about feelings, I guess?
Well, so talk therapy can be CBT, or it can be something else. Or if it's just sort of, I'm going to go to somebody and sort of tell them what's on my mind each week, that can be beneficial. I mean, sometimes just getting things off your chest. And that can happen with a therapist or with somebody else, like a friend or something like that. That can be helpful, but it's not what I would recommend as first line for a kid with anxiety, because there are specific elements that we know are helpful that's going to be missing if that's all you do.
I was going to ask, is there any evidence that beginning a child on medication at a younger age may lead to not needing medication and go on?
The question is there any evidence that putting a kid on a medicine at an earlier age prevent them from needing it as they get older? The best answer that I can give you for that is that kids that respond to medicine, so you give a child a medicine and their anxiety gets better over the next few months, that child is less likely to have problems with anxiety as they get older than if they don't respond to the medicine or if they never get treated. But it's, does that sort of answer your question? No. So usually the goal with medicine if it's just anxiety, we're not talking about anything else, but a child just has an anxiety disorder. Usually what we're trying to do is get them well first, and either with just a medicine, just therapy, or a combination. And then once they're doing well for, say, a year or two, usually, then we try to see if they can come off the medication. We almost always want them to have gone through some form of therapy before that, so that if a little bit of anxiety comes back, they have other tools to kind of manage that. There are some people, though, that are, there are some kids that we try to take them off and they continue to have anxiety and then we go back on. I can't give you sort of a specific number about that. The other thing to say about that is that, no one, some people want to try medicine, some people don't. And it's a very sort of personal and family-based decision. We've been using these medicines for a long time. The type of medicines that are used for anxiety are called SSRI, selective serotonin reuptake inhibitors, things like Prozac, Zoloft, Celexa. And we don't have any evidence that being on these medicines over a long term has any negative effects that we can tell in kids. But we do know that being really anxious or being really depressed over your childhood is associated with later problems. So in my mind, medicine, and being well and being on medicine is safer than being off of medicine and being sick. But again, it's a sort of a personal decision. Yeah?
Is the effectiveness of treatment, is there a difference between anxiety, like hereditary, or anxiety due to trauma?
So the question is there a difference between anxiety that is hereditary, maybe not associated with trauma, versus anxiety associated with trauma? Yes. So the way that, so I'll backtrack a little bit. It depends on the specific kind of anxiety the person exhibits after the trauma, or if it's repeated trauma, the kind of symptoms that they're showing. I'm sure you're familiar with PTSD, right? The set of symptoms that comes up after someone has had trauma, and that's usually things like having intrusive thoughts of it, maybe nightmares, or seeing it, like having a flashback, avoidance of things that remind them of the trauma, and there's a version of cognitive behavioral therapy, CBT, that we use specifically for kids that have trauma. And in fact, we have a large program at WashU of trauma-informed providers and therapists. So it's a little bit different. That being said, some people after a trauma will experience something like separation anxiety or generalized anxiety disorder. And we would treat those the same that we would treat any other anxiety disorder, but addressing the trauma as it comes up as well.
Want to touch on just what you were talking about, the trauma anxiety. Okay, how do you treat trauma anxiety with twins? One of them has trauma anxiety and social anxiety, and the other one does, but not near as bad as the one who has the trauma. Would the same therapist,
I mean, that's a specific question for that therapist. Sometimes we don't do that just because sometimes it can be hard to trust somebody who another family member has seen. You might feel like you can't be completely honest because they might slip when they're talking to the other person. Not everybody has that fear, so it depends on a particular situation. That's really challenging.
It is.
And you certainly have to address the fact that the other twin has a problem because it would be easy for them to sort of interact in a way that could make the anxiety worse, right? Or they could reinforce each other's kind of bad habits. And so I think it would be important to be thinking about that. And sometimes we do family therapy as well. So sometimes we find that we have to treat the whole family unit in order to address the anxiety because the child alone is not the only reason that the child continues to have anxiety. There's other kind of things that are happening within the family, and then we have to change what we're doing. So again, this is sort of an oversimplified version of what we do, and we're just focusing on the child. Yeah.
Once you have an appointment, what is reasonable to expect for an evaluation of your child? Do they just interview a therapist? Is it surveys?
Yeah, so the question is about what happens in an evaluation or what should you expect in an evaluation. Different providers do it differently, and it depends on exactly what you're asking about. So if you're asking for a psychiatric assessment or a sort of general look for psychopathology, which may also come from a psychiatrist or a psychologist or someone else that's trained to do a mental health evaluation, the primary way that we evaluate the child is to interview the child, interview the parent, and sometimes each of them alone and each of them together, asking about specific things and also observing the child. Often we'll couple that with questionnaires that provide supporting information, but the majority of the information we get just directly from the interview. And that's what we do. So in the research studies that we do interviews of the child alone, we interview the parent alone about the child, and then we have a series of questionnaires, and that's how we come up with the diagnosis for the study. And we, it has to be comprehensive. So if someone comes in for anxiety, we can't just ask them about anxiety. We don't for the research study, right? We ask about depression, ADHD, and autism, and everything else. There are other providers that do things differently. So there are some say neuropsychologists that will have a slightly different bent, and they're looking at more sort of how different cognitive styles or the way that kids think and what their strengths and weaknesses are. And they have more sort of formal kind of tests or tasks that they ask the kid to do that gives sort of a number about how good their verbal memory is, or versus their verbal IQ versus their nonverbal IQ, or their processing speed, things like that. So that's a different kind of evaluation. We also have sort of more formalized observational things that we sometimes do, where we formally put kids in particular situations and watch how they react. But usually it's based on interviews primarily.
Do you find that a lot of kids with anxiety also have mood disorders?
It's common. So most don't. Most kids with anxiety don't have mood disorders, but a lot of them do, and they're more likely to have a mood disorder if they have a problem with anxiety. And so usually that's something like depression, sometimes other mood disorders. the kids that we end up seeing in child psychiatry offices, a lot of them have mood disorders, because we tend to see the kids, obviously, that are the sickest, right? Because a lot of times they will be managed by the providers if they just have an anxiety disorder.
My son has been diagnosed by 2 psychologists. They both went to school together. They've been in the field for the same amount of time. Medically, he was diagnosed with social anxiety disorder. Educationally, he was diagnosed with autism. So my question is, in trying to manage anxiety, is that the same as if we have anxiety, or do we need to really, I tend to lean towards just as a professional, but as a mother, being that he's more social anxiety disorder, and then just showing the autism based on the anxiety. How do you have, like, how do I know how to do that?
So in general, you want to be thinking about other things that are going on. And they may be subtle, they may be slight, or they may be more extensive. And certainly the way that we do therapy with kids that are anxious that also have, say, something like autism is different than the way we do therapy with just a kid that has anxiety. It depends a lot on the child. So it is tough. So autism is usually defined by lack of social interest, just at all, right? Or difficulty in social interactions, and sort of not sort of intuitively knowing how to interact socially. And so you really have to see if you can find whether or not the child has any interest in social interaction, which is a little bit different than fear, but it can be tricky. I'm also happy to, we could wrap up, I'm also happy to sort of take a few kind of, people can just kind of walk down those questions. Thank you, guys.
Thank you all so much for coming. I will post the list that they send us to the Parkway website. I'll also give it to our communications department, so if you found out about this like via Facebook or our Twitter, we'll also send that out that way as well. Thank you all so much for being here.